Good evening, one and all. Welcome to ISA Telangana Webinars. This is our fourth webinar in 2022. So we are hoping to continue these webinars continuously. So today's speaker is Dr. Rakesh Garg, Additional Professor, AIIMS, New Delhi, and he is also Secretary of the ISA Delhi State Chapter. So today's topic is Postoperative AKI Management Principles. Today's webinar is Dr. Pavani, Professor of Anesthesia, Osmania Medical College. So I request her to take over. Thank you.
Good evening, one and all. A warm welcome to all of you on this pleasant evening to have another feast from Dr. Rakesh Garg. Dr. Rakesh Garg is a well-known personality. He is the Additional Professor, Department of Onco-Anesthesiology and Palliative Medicine, All India Institute of Medical Sciences, New Delhi. I find it a great opportunity to introduce him and to just cite all his achievements. He has over 260 publications, both in national and international journals. He has authored 25 chapters in various books. He is also the editor-in-chief, Journal of Onco-Anesthesiology and Perioperative Medicine, and the associate editor of Journal of Anesthesia and Clinical Pharmacology, and also Journal of Medical Case Reports. He is a trainer and instructor for BCLS, ACLS, etc. And he has delivered over 100 guest lectures and has chaired various sessions at various national conferences. And his areas of interest are onco-anesthesia, airway research, cancer pain, and palliative medicine. He was also awarded many awards from the ISA. He received the ISA Presidential Award in 2015 and 2017, and last year in 2021 for his contributions towards ISA. A warm welcome to you, sir, to this evening. So please, we are waiting for your oration, sir. Thank you, sir.
Thank you so much, ma'am, for the kind words, and thank you, Dr. Reddy, and all the team of ISA Telangana for this academic initiative and kind invite. So today's is an interesting topic because whenever we talk about the perioperative care, the kidney injuries remains one of the important aspects that we need to remember, and timely management of these events are important because if you manage them on time, the outcome becomes good. But if they are delayed for some purpose, the residual effect on the renal function and subsequently on other systems will be left as a residual effect. And this will affect the overall outcome of the perioperative care, overall outcome of the quality of life of the patient subsequently, because there is a lot of sequelae for the chronic disease, chronic renal disease, which happens in these patients. But at times, if we follow the basic principles, which I will be taking through today, probability of acute converting into chronic phase can be taken care of at many places. But yes, some of the times it will not be possible to reverse back to the normalcy. But then kidney having its own reserve will be able to manage even if some injuries as a residual effects come up. I work at All India Institute of Medical Science. I am more concentrated towards the onco cases, cancer surgeries, which we have at BR Ambedkar Rotary Cancer Hospital, and we have an independent standalone 720-bedded onco center, which has become functional for the last 4 to 5 years. And we have almost more than 18 theaters in onco centers and 50-bedded ICU, which is taking care of onco critical care separately among the cancer patients. Now, when we talk about the kidneys, we agree that for many reasons, kidneys are important for us. They remove the toxic materials. They help to remove or maintain the fluid inside the body. They do have some hormonal balance. They regulate the electrolytes into the body. They maintain the metabolic homeostasis in the body. But what happens when kidneys are taken off, right, for whatever reasons, right? It becomes a serious issue because we cannot afford even a single day, a single hour for our kidney not to function. And this is what is acute kidney injury. And this is what we need to not only assess them timely, but also manage them subsequently so that we are able to preserve the renal function. When we talk about the perioperative management of a patient for any condition, there could be two situations. When we talk about acute kidney injuries, there could be a pre-existing renal dysfunction, and then they can have add-on an acute kidney insult, which can lead to further or precipitate the acute shutdown of this kidney on a background of chronic condition. And this becomes an acute challenge, a unique challenge for the anesthesiologist to prevent this sequelae. And this requires a very strict evaluation and optimization of these patients to prevent such type of events, adverse events, and hence just to reduce the morbidity and mortality. The optimization of patient with renal dysfunction can reduce the possibility of acute kidney injury. Now, this is an important aspect because there are certain preventive strategies in the perioperative period that we need to follow, whether the patient has pre-existing kidney injuries or not. If you follow those optimization methods and take certain precautions, the chances of AKI in the post-operative period will be much reduced. We cannot say it will come zero, but yes, it will be reduced and the impact or the severity of AKI will come down. The anesthesia and renal functions are connected and can interfere with each other. We know that if the renal functions are impaired, there will be a lot of hemodynamic fluctuations, the respiratory compromise, and so many things. System physiology will change during the perioperative period when these patients are given anesthesia, whether we talk about the general anesthesia, the regional anesthesia, whatever it is, they are connected to each other. And hence, we should be cautious about the effect, adverse effect, or you can say even toxic effect of these drugs on the renal function, and that needs to be taken care of. Decreased renal function can affect the outcome of the perioperative anesthesia management because various drugs are secreted or excreted by the kidneys, and hence their effect, their pharmacokinetics and dynamics would change. The perioperative renal failure and renal protection is a crucial moment in the clinical practice of every anesthesiologist, and hence we should take utmost care not to even insert a single nephron, because especially when the patient has advanced kidney disease, all those nephrons are important to us for preventing long-term morbidity and mortality in these patients. Now, I'll be just focusing on today's talk on two aspects here. What if a patient is not having any pre-existing kidney disease and because of any reason, surgical reason, or because of drug toxicity, acute kidney injury happens? This can happen like in case, for example, those patients who are going nephrectomies, those patients are going intra-abdominal surgeries where a lot of handling or the vascular supply is inhibited. Also, sometimes nowadays we give, especially in cancer patients, something called intraperitoneal chemotherapies, hyperthermic chemotherapies, and they can lead to AKI in the immediate post-operative period, even when they don't have pre-existing any kidney disease. On the other aspect, there could be a patient with chronic renal dysfunction, and any further insult can lead to acute or chronic kidney failure. So I'll be just taking both these aspects a little bit with regards to the acute kidney injuries. And it becomes very, very important for us as anesthesiologists that whether they don't have previous AKI, previous renal dysfunction, or they have, we have to take all precautions that nothing happens to the kidney. The functions remains normal as it was preoperatively, even at the postoperative period, early identification and management. Now, as we all know that chronic renal disease is primarily based on certain parameters. All of us know it very well. I may not be going into detail. It's defined as abnormalities of kidney structure or function for more than 3 months with implications for health. Usually, when we try to grade it, it's usually based on the GFR. But then for its diagnosis, for the criteria for CKD, we look for 1 or 4 markers of kidney where we talk about the albuminuria, which is an important aspect. We look for the urine sediments, the abnormalities in the electrolytes. Any biopsy taken from the kidney shows histological changes out on the imaging basis, or there is a transplanted kidney. So these are considered to be markers for kidney damage. And then they are further graded based on the GFR. And if you see this, this classification of Kitco classification, which is more specific and important, where they talk about just not the GFR, they also talk about the albuminuria. So whenever we talk about the kidney damage, kidney disease, we have to talk about GFR, which is in turn related to some amount of urine output and other things. And on the other aspect, the albuminuria, which is seen in these patients because of the renal dysfunction. And based on this, they have been classified into further categories as G1 to G5, grade 1 to grade 5. And based on the albumin, A1 to A3, when they have more than 30 milligram per millimoles of albuminuria in the urine. And if they have a kidney failure with GFR of less than 15 ml per minute per body surface area, they will be in the red area. So anything in the red area is considered to be a very important challenge in the perioperative period, because these are the patients who probably can precipitate into acute renal shutdown, and probably they will require some amount of renal replacement therapy in the perioperative period. On the other hand, the orange and yellow patients may be managed conservatively. On the other hand, green appears to be stable, but we have to take care that no further insult happen to these patients. The most common diabetic and hypertensive, these are the commoner conditions in India, and these are the reasons for CKD, and hence it becomes essential that the diabetic status and the hypertensive status should also be monitored and optimized in these patients. But what actually happens in chronic conditions, why are we worried about? Is it only the kidney, or it is affecting the other systems also? Yes, it do affect other system, because it's just not the kidney, as I mentioned at the beginning, it's just not the secretory function of the kidney. It is also involved into the hormonal system of the body, the renin-angiotensin-aldosterone system, which is related to many other aspects of the body system. And this is one system where which is affected and which can affect the blood pressures and the cardiovascular status. Also, when we talk about the kidney damage, we are talking, as I just mentioned, about the protein loss. So whenever the protein loss happens in the body, they will lead to further changes that can lead to proteinuria, leading to low albumin levels, dyslipidemia, and other metabolic changes will happen in the body because of the non-functional renal tubules and other parameters. And that's why this whole system will lead to damage to the glomerulus, damage to the hormonal system, and finally leads to various functions of the kidney affected. And since once they becomes affected, the abnormal kidney will lead to effect on the other body system also. And in fact, if you see the impact on the renal shutdown is almost on every patient. So whenever these patients comes up with acute renal failure on a chronic background disease, these patients would be having these systemic issues. And hence, in a post-operative period, if a patient gets or manifests acute kidney injuries, probably these manifestations will be further manifested. It's just not the urine output which is going to decrease. It's just not the blood urea or serum creatinine levels which will go high, or the urine output will go down. But also there will be other effects. For example, there will be a lot of congestion in the body. There could be pulmonary edema. There could be pulmonary effusion, and the patient can manifest respiratory issues. There could be some amount of bleeding from the GI system. There could be coagulopathy. Uremic coagulopathy is important. So any amount of acute insult on a background of chronic kidney injuries will precipitate the symptoms, and hence it becomes important to evaluate them preoperatively, try to optimize them, and in case if acute insult happens, look whether these abnormalities has been taken care of. They can be further precipitated further on, and hence it becomes important not only to look for the renal replacement therapies, but also the other systemic support in various modalities, so that the outcome of the patient becomes better. Now, let's talk about any surgical procedures. If it may be because of direct handling of the kidney organs, or if there's some vascular damage, or if there has been hypothermic installation of the chemotherapeutic agents. These are the factors. I'll come a little later what other factors are. They can precipitate acute kidney injury, and it is defined as increase in the serum creatinine of more than 0.3 milligram per deciliter within last 48 hours, or increase in the serum creatinine more than 1.5 times known to have occurred within prior 7 days. And this is important when some patients have grade 2 or grade 3 chronic kidney disease. In those situations, the increase by more than 1.5 times of the basal value for these patients is an indicator that yes, acute kidney injury has happened. And this should also be along with the urine output, which is less than half ml per kg per hour for 6 hours. So this becomes a diagnostic criteria, which is based on critical criteria for diagnosing acute kidney injuries. And this needs to be done on an hourly basis, because once this acute kidney injury try to settle down, unless if there are some reversible causes, we don't try to reverse them at the earliest, the chronicity or the chronic nature of the kidney damage can proceed with. Now, there are various classifications that has been used. More recently, the Kitco classification is common being used, but the rifle, the Akin, and the Kitco classifications are are various other classification for acute kidney injury. It is kidney disease improving global outcomes is one of the commonest parameter, and all the three classifications are primarily similar to each other, though they have divided into different types. They are primarily based on the serum creatinine, which says that they should be increased by around 1.5 to 2 times of the normal basal value, and the urine output usually less than 0.5 ml per kg to say them that they are stage 1 acute kidney injuries. And subsequently, if the serum creatinine goes more than 3 times of the basal value and the urine output is less than 0.3 ml per kg per hour for more than 24 hours, they become the highest grade. So this is just a brief summary of this classification that I have come forth with. And in case if they persist with this, the acute kidney injuries is termed as end-stage renal disease. If those serum creatinine levels and urine output persist for more than 3 months, they will be labeled as the end-stage kidney disease, or you can say the chronic kidney disease criteria will be fixed on. Now, why AKI happen and what strategies we should follow so that maybe as a preventive strategy, or in case if we can identify the reversible cause, whether to treat them. So broadly, we can divide them as the pre-renal, the post-renal, and the intrinsic renal condition. Now, intrinsic renal disease can happen most commonly, like for example, say we have used some nephrotoxic disease causing acute tubular necrosis, or they could be hypoxic episodes. Sometimes the clamping of the renal vessels is required during the surgical procedure, or they could be a disease like multiple myelomas where the cast can be deposited. So that leads to the obstruction and dysfunction of the renal tubules, leading to the renal damage. They could also be related to the other interstitial aspect, like in sarcoidosis and myelomas, and that will again lead to intrinsic renal disease. But more commonly, the causes in the perioperative period are primarily related to the pre-renal cause, and the hypovolemia is one of the important aspects. Whether I talk of hypovolemia generalized or hypoperfusion to the kidney because of the abdominal surgeries, these can lead to pre-renal factors for leading to the acute kidney injuries. There could be other conditions like sepsis. Again, these will be having an impact in renal artery stenosis. Use of drugs like ACE inhibitors and NSAIDs specifically in a single kidney, and these are the reasons which remains for leading to reduced renal perfusion and thus the pre-renal type of acute kidney injuries. Post-renal is most commonly, as seen in our setup, is obstructive one, where there could be because of the disease process damage to the ureter, maybe because of edema or some injury to them, or they could be fibrosis or kinking of these vessels. There could be prostatic hypertrophy. There should be strictures, or there could be renal papillary necrosis that can happen. So these are the post causes, and majority of them remains the obstructive nature. So when we say these principal causes, majority of time, and I just mentioned, the principal causes in the post-operative care is, as seen into our Indian scenario, is primarily leading to the volume deficit. The other is related to the hemodynamic instability, and third is the sepsis. And more commonly, when you are looking for non-operating room anesthesia, where we use a lot of the various nephrotoxic agents, contrast agents, sometimes they can lead to nephropathy. But now we are using most commonly non-iodine containing contrast agents, so chances of toxicity are much less in these group of patients. Now, why this AKI happens, and what all we can do is primarily whatever the insult that we have talked of, whether it is pre-renal, post-renal, or intrinsic renal, there will be some component of hypoperfusion. And this is just not hypoperfusion. The moment the hypoperfusion starts happening, a cascade of neuroendocrine response will start happening. There will be a release of various inflammatory markers, and that will lead to inflammation inside the kidney. And you must have seen that if you see the imaging of these patients, the initial insult may be an hyperactivation. I'll come a little later. There will be more amount of urine output, and if you see the imaging, the kidneys will be swelled up during the initial phase of acute kidney injury. So this is what is actually happening. In spite of the decreased renal function, in spite of the hypoperfusion, the kidney size is increased. A lot of inflammation which happens, and this will lead to the various autoregulatory phenomena abnormality, and that leads to the various release of vasoconstrictors, and this further on release the renal blood flow, and this causes more of a renal tubular ischemia, and this finally leads to reduced GFR. So this reduced tissue hypoxia because of all those pathology that is happening, that stimulates the extracellular matrix production, and subsequently they will be healing by collagen deposition and fibrosis. So that's why I say the management of acute kidney injury is important, because if we can manage it the earlier phase, this collagen deposition and fibrosis can be prevented. But if not, they will lead finally to the necrosis of these, and finally the fibrosis will happen, which will become non-functional part of the kidney. Not only this, if you see the other aspect, this is like, for example, say sepsis situation or the acute stress response of the surgical insult. They will have systemic inflammation, and the body will also release various cytokines, whether they are TNF factors or interleukins, and that will further cause tubular injuries, because they will be secreted into the renal tubules and they will cause further damage to them. So this means the etiology overall is multifactorial. They are related to RAS, they are related to the renal microcirculatory dysfunction as I just described. It also relates to increased oxidative stress leading to the production of free radicals. They are also related to the cytokine-induced injuries, endothelial cell injuries, and activation of pro-apoptotic pathways. So this means the acute kidney injury is just not the damage of few nephrons. They are having various insult, various mechanisms, and many of these mechanisms will be able to prevent, and some we can reverse them back, but some may not be. So we have to take all preventive measures so that this cascade of activities are not taking, not gets activated, because it will be really difficult to control them once they get activated, and they will have some persistent effect. So this is how what we need to look for. And when we say the acute kidney injury happens, it's just not the kidney. They will have impact on almost other organs also. They will affect the brain. We have already heard about the uremic encephalopathy. There will be some amount of brain edema, because once the uremia starts happening, the capillaries becomes leaky and the detoxification does not happen. So both things are happen. So whatever the toxins are there in the blood, because of the leaky capillaries, they will be into the brain, they will be into the heart, they will be into the lungs, they will be into the liver, and they will further cause further cascades in affecting the functions of other organs also. And they also affect the immune system of the body, which we very well know that the patients with renal insult do have suppressed immune system, and they are more prone for infection. So this becomes a vicious circle. Now, this is a little newer strategies which has come up in last couple of years, where they call about panic cell-mediated multi-organ systemic inflammation after acute kidney injuries. Now, this is the important aspect, because once the cascade of AKI happens because of any insult, this will have multiple effects on the other organs. And the data which comes up has clearly defined that once this happens, there will be a lot of secretion of various markers into the body, affecting the whole system. And primarily they're related to the tumor necrosis factors and interleukins, which are primarily responsible for multi-organ systemic inflammation, leading to multi-organ systemic dysfunction. And hence, the acute kidney injury probably is not an organ injury. Acute kidney injury probably is a syndrome affecting various body systems. Now, when we talk of AKI, body usually has a compensatory response. And AKI, when you talk about, it will take a couple of hours to days to settle down. And this all depends upon the underlying etiology that is leading to AKI. We have already discussed about the pre-renal, post-renal, and increasing phase. The onset phase is usually an acute event, maybe like acute blood loss in trauma patients, or a major surgical procedure with a lot of blood loss and fluid replacement. And herein, because of the edema, because of the injury, because of the inflammation, the tissue perfusion is decreased, and it may be for hours to days. And the urine output, though, appears to be normal, but it will be on the lower side. And then comes the oliguric phase, where the patient will be having a renal shutdown for some time, which will be usually less than 0.5 mils per kg per hour, and it will be somewhere less than even 100 ml per day. And this may be for around 1 to 2 weeks. And then these patients, when the body starts response to it, there could be a diuretic phase. Sometimes the oliguric phase is a little shorter and diuretic phase is much higher. And this occurs when AKI is being either compensated by the body, or we are trying some treating some reversible causes. And at this phase, the kidney starts producing more of urine. It persists for a week to 2 days. But then remember that at this time, the tubules are recovering. They may be leaky. They are scarring. They have edema, and the urine output goes much higher. They may have now electrolyte imbalance because the urine output is much higher. And then subsequently, the kidney starts tolerating themselves. They try to recover, and probably the renal functions come back to normal, but not exactly to 100%, because some amount of edema, inflammation will lead to scarring and fibrosis, and this will lead to some damage to the nephron, and this can persist for even up to 1 year. So this means actually acute kidney injury is not acute phenomena of a couple of days to weeks. It continues for a longer duration, and hence it becomes very, very important to follow up these patients. Now, just to summarize, I'll not be going to the intraoperative management because topic is regarding the postoperative period. But what you know that we usually follow the traditional approach where we talk of the aggressive hydration to prevent all those things, the placement of the fluid and the blood loss with the blood products or the crystalloids usually. And this is the basic thing that we go for. And even if we talk of the ERAS protocols, again, the ERAS protocols are applicable to various surgical procedures, but again, they are not concentrating more on the fluid replacement part. And there has been some debates of fluid restricted regimens versus goal directed regimen. And these are the basic principles that probably would affect on. Having said that, whatever the technique that you are following is, what we need to optimize the patient status preoperatively if we can do for them. To try to evaluate for any fluid, acid, base, and electrolyte imbalance in these patients. The kidney patients usually have anemia, they have coagulopathy, try to treat them and correct them. These patients already have some amount of diabetes and hypertension, which may not be controlled, try to optimize them. And also there will be some other disease, like I mentioned about GI, I mentioned about liver, I mentioned about respiratory component, try to evaluate them and manage them. Now, why we are managing this? Because if any underlying kidney damage is there and these functions are abnormal, any small insult, the kidney will not be able to tolerate and it will have acute insult. And that will lead to acute renal shutdown in the background of these patients. In case these patients are on dialysis, depending upon what type of dialysis, hemodialysis or peritoneal dialysis, they need to be continued because they will detoxify to a certain extent and will give you a leverage in the perioperative period to prevent subsequent kidney injuries. Also try to look for what type of various type of dialysis they are undergoing, the frequency of dialysis, the time and date of dialysis, usual fluid intake, and usually we talk about the dry weight of these patients, so that this will give a fair idea that how much fluid loss and fluid compensation can be tolerated safely by these patients. That needs to be assessed when we are talking about. Dry weight must be noted for these patients. The baseline investigations should also be looked for, urea, serum creatinine specifically, serum electrolytes specifically, and the treatment that is being received for diabetes and hypertension should also be looked for. Regarding the intraoperative period, because we want to prevent them the occurrence of any further insult in the AKI, try to look for so that these patients who are having any underlying kidney disease, they are being taken care so that we are not exaggerating the systemic insult to these patients, whether we are talking of aspiration prophylaxis, we are talking about various drugs that are excreted by the kidney. We talk about the position of the patient that can lead to exaggerated hypotension, like sometimes positions of Trendelenburg and all those things. And when we shift the position, they can have transient reduction in the blood pressure that can affect the renal perfusion at times. Also, we need to think of that we need to monitor. We need to have something called goal-directed fluid therapy for these patients. So probably will require the monitoring accordingly. But when we do a lot of invasive monitoring, remember that these patients, as I mentioned earlier, are immunocompromised. Their immunity is affected by the renal dysfunction, and hence we should be following very, very septic environment for managing these patients, aseptic environment for these procedures so that they cannot catch up any potential source of infection from whatever we are doing. We also need to look for all these parameters which can further precipitate or exaggerate further injuries to the brain or the other organ systems in addition to the kidney. And hence it becomes very, very important to look for these factors and try to optimize them And simultaneously, these are the factors which will be affecting our perioperative outcome, which will affect the various kinetics and dynamics of the drugs that we're using. And when we are talking of the outcome, for example, say these patients will have some amount of electrolyte imbalance. The body fluid redistribution will happen in these patients. The drugs which are excreted by renal function may not be excreted properly, and hence they may be on ventilator for a longer time, leading to infection, leading to sepsis, which again becomes a reason for AKI. And hence, we need to look for all those parameters and try to manage or make a plan for the perioperative care for these patients. If we talk about the various other things in the postoperative period, so I'm just moving towards the postoperative aspect, we need to look for, because these patients of acute kidney injuries, the duration of the drugs of various opiates and benzodiazepines will be prolonged. They do have almost the CNS blood-brain barrier is disrupted in a uremic patient, and hence we should be cautious that we should not be giving them longer-acting drugs, whether we talk about benzodiazepines or opiates. We should also be monitoring them for neuromuscular blocking agents, because drugs like vecuronium, rocuronium, they will have more duration of action, and hence if we use drugs like atracurium or cis-atracurium, we can extubate them faster, chances of infections reduces, chances of acute kidney injury reduces. We need to monitor them for cardiac dysrhythmias, because electrolyte imbalance can happen. Look for the function of the kidney in these patients. Be cautious about the fluid, because they can manifest pulmonary edema. They have leaky capillaries, so even pulmonary edema, a fluid overload can lead to pulmonary edema, and hence will affect the extubation and recovery for these patients. Bleeding may be an issue that needs to be taken care of. And in case if these patients are showing this phenomena, probably to prevent even the AKI, if these various parameters are abnormal in the immediate postoperative period, probably a need for the renal replacement therapy may be considered in these patients, though there's little controversy with regards to the early CRT versus late CRT based on the outcome. But then if there are some causes, some monitoring parameters or the investigation parameters which should be raised affecting the body system, probably there is an indication for CRT to be done in these patients. Now, what we can do, how can we protect the kidney from the injury to happen, and what all modalities we can follow for protecting the kidney in the perioperative period. First is we need to identify the risk factors. We need to identify which group of patients will be at high risk for the development of postoperative acute kidney injuries. And if you can just read these factors, preoperative and intraoperative, these are important. The elderly patients, the female genders, the body mass index, especially those patients who are obese, uncontrolled hypertension, presence of chronic kidney disease, insulin requiring diabetes mellitus, patient with COPD, patient with peripheral vascular disease, patient with chronic congestive heart failure, any focus of infection in these patients, and presence of ascites. So these are the factors, patient-related factors in the preoperative period that will increase the chances of occurrence of AKI in these patients. And any prolonged duration surgeries, intraperitoneal surgeries where there's a lot of handling of the kidneys and perinephric tissues, the vascular surgeries, the prolonged uncontrolled hypotension, transplantation of solid non-renal organs, transfusion of RBCs. Now, this is an important aspect, because if a lot of blood loss happens and we are transfusing them a lot of blood products, even the RBCs, they can lead to these risk of AKI. The intra-abdominal hypertension, this is common, especially when we undergo major intra-abdominal surgeries. The abdomen is very tight at the end of surgical procedures. They can lead to the perfusion deficit to the kidneys, and the chances of AKI can happen. And especially the cardiac surgery, so we'll not be discussing about the cardiac surgeries now. They are the independent risk factors for the occurrence of AKI, especially for the cardiac procedures. And the use of nephrotoxic agents like NSAIDs, antibiotics, and contrast agents, though intraoperatively may not be using them much, but then if they have received very recently and for some reason they are being administered in the postoperative period for some other assessment, they can manifest in the form of acute kidney injury. So based on this high-risk population, you can identify them. and then you need to diagnose them. We already mentioned the Kitco criteria for acute kidney injuries. You can use Rifle and Akin parameters also. But then most commonly, what we do is the urine output is a less useful criteria for this, because there will be many other factors for affecting the urine output. We may be using the drugs, we may be giving a boluses of fluids, we may be using diuretics at times for some reason, and hence urine output may not be a very important or very clear indicator of the acute kidney injuries. They are usually decreased in the intraoperative and postoperative period because of the other hormonal effects, and even because of the anesthetic effects, and hence the identification or indication of urine output as an isolated marker for the acute kidney injuries may not be always indicator of occurrence of acute kidney injuries. Even if you talk about the serum creatinine, is also a flawed diagnostic tool and can be an inaccurate marker of GFR at times. Creatinine will begin to rise after a GFR is decreased by 50%. If patient is not having any kidney disease in the preoperative period, is not a CKD patient, probably even the creatinine levels will not fall. They will retain, because we know that until and unless the 50% of the glomerulus are damaged, the kidney functions will be normal with regards to the urea and creatinine levels. And hence it becomes important that sometimes, because the kidney function is working, the urine output is coming, or sometimes the lower side, it becomes difficult to diagnose them, what parameters that we have already mentioned. Once the patient is having chronic kidney disease, it becomes easy to diagnose for AKI, acute insult over a chronic disease. But those patients who does not have a renal disease preoperatively, and if they have AKI, it becomes difficult to diagnose early because of what I just mentioned. And that's why the novel markers of AKI has come into picture, so that we are not waiting till time that 50% of glomerulus are damaged, and then the creatinine level starts rising, and then we diagnose AKI. So nowadays, whenever we have suspicion based on the risk factors that I just mentioned, these novel biomarkers are coming into picture, and they are being used to identify whether acute kidney injury has happened in an otherwise even a normal healthy kidneys preoperatively. Neutrophil gelatinase associated lipocalin is one of the very important marker that has come, and various data has come up. Its specificity is much higher, 70 to 80%. Though sensitivity is on a lower side, but yes, it is able to gives the idea of the occurrence of acute kidney injury, though it may be affected by infections or certain tumors, even cardiovascular disease. But this marker, NGAL marker, is coming up as a promising tool for identification of the acute kidney injuries in the postoperative period. The kidney injury molecule, the KIM molecule, is also a membrane glycoprotein that is released from the kidney cells once it is inserted, either because of the hypoxemia or because of the direct effect of any nephrotoxic drugs, especially like nephrotoxic contrast agents or NSAIDs, and these are released into the body. And this is a very highly sensitive biomarkers. Again, this is a promising tool. There's more use for acute kidney injuries where they do a clamping, and chances of hypoxemia or ischemia is much higher, and they can be used. Having said that, the single marker, sometimes, as I mentioned, they could have overlapping regions for its increase. That's why a combination of markers are being used. Similarly, cystin C and tissue inhibitor of metalloproteinase and insulin growth factor binding protein 7. These are the other two markers which are being reported to be having effect on their levels once acute kidney injuries happen. Cystin C is a very small charged molecule completely filtered at glomerulus, where it undergoes catabolism by proximal tubule cells, and usually it does not come into healthy kidney. But once it starts coming, it usually starts after 6 hours of AKI. It is filtered out of the proximal tubule of the nephrons, and the levels cystatin C starts increasing once AKI has happened. And similarly would be about the tissue inhibitor of metalloproteinase 2 and insulin-like growth factor binding protein 7. These again molecules are depictive of possibly acute kidney injuries. Now, once we say that these markers are increased, if you see this table, this is a nice pictorial representation of all the markers I just mentioned about, NGAL, KIM, cystatin C specifically, and also we talk about the creatinine levels. If you see this line, the creatinine levels will remain very constant for some time. It will take some hours to start rising. But if you see the other markers, if you see the NGAL, they will start speaking within the next 2 to 4 hours. And hence it becomes very important that we can identify these patients rather than wait for the serum creatinine levels or decrease in the urine output, which will take a couple of more hours, and then the injury will be more settled down. Rather than using these markers will help us specifically in those populations where we have high index of suspicion based on the risk factors which mentioned earlier and based on the intraoperative insult to the kidney. If somebody, say if some patient has sustained hypotension for a longer duration, a lot of handling, retroperitoneal handling has happened. Now we should look for these markers because these markers will be helping us to identify the occurrence of acute kidney injury even before the renal serum creatinine level starts rising or the urine output starts coming. And hence we can take all other precautionary measures like giving them fluid replacement, which are coming a little later. So what we can do for prevention of this, we need to identify the high risk factors and then look for the monitoring accordingly, right? And primarily what we are looking for, removing the factors which can cause injury. So don't try to use nephrotoxic agents, absolutely avoid NSAIDs in this, no contrast-enhanced CTs for these patients, and try to maintain the volume status using a goal-directed fluid therapy for these patients, and closely monitor various parameters of renal insult, and definitely try to control the blood pressures and sugar in these patients. And if you are using markers are available, try to identify them. And if they are rising trend, then try to look for that what is lacking. Is the fluid status not well? Is the diabetic not well controlled? Is the kidney perfusion not happening properly because of surgical reasons? And that needs to be taken care of. Now, this is again an important aspect of the fluid replacement therapy because we were talking a couple of decades back about the liberal fluid management, then comes the restricted fluid management, then people were talking about the goal-directed fluid management. So there has been many concerns, but if you see this important trial, relief trial in 2018, they mentioned that the restricted fluid regimen was correlated to higher rates of AKI as compared to the liberal fluid, 8.6% versus 5%. And they also mentioned that modestly liberal administration of balanced salt solution. Earlier studies were using chloride-containing solution, but here they mention about the balanced salt solution does not create substantial fluid retention. And hence we can use them appropriately for a fluid status which slightly exceeds zero fluid balance on the background of chronic kidney disease. Now, this is an important study where we are out with the restricted fluid regimen and we are in with the use of balanced salt solution for these group of patients. But then probably when we talk about the liberal fluid, yes, it becomes how much liberal? How much would be the extent of the upper extent of giving liberally to them? Because we know they have leaky capillaries, they will lead to pulmonary edema, they will lead to cerebral congestion, they will lead to hepatic congestion, and hence we should be talking about some upper limit also for that liberal. People have used various volumes in them, and then it comes what is the goal-directed fluid therapy for these patients, where they will target some outcome parameters, which is in the form of the cardiac index threshold, which has been used in the studies, and they found that if you try to maintain it 4.5 liters per minute per meter square of the cardiac index, probably the perfusion appears to be okay in these patients, and that's the appropriate amount of fluid. And again, they are using balanced out solutions here, and the renal perfusion remains better. Now, if you see the study, I was just mentioning the balanced salt solution. If you see the older parameters, they were using a lot of colloids. They were using the chloride-containing solutions like 0.9% sodium chloride containing solutions. And this trial, the CHEST trial and the SAFE trial, they were important with regards to the choice of the drugs. The balanced crystalloid solution, which has composition of various electrolytes very similar to plasma, is now the preferred modality or different type of fluid that needs to be used for volume resuscitation in patients with either chronic kidney disease or those patients in which we suspect or manifest acute kidney injuries. So this trial has confirmed that the use of these drugs are important to be used in these patients. Not only type of fluids, probably what is recommended in this important article, which was published around 5 years back, that we have to maintain the pressures here. The mean arterial pressures should be maintained between 60 to 70 millimeter of mercury to prevent AKI, and if the AKI is already happened, try to maintain at these pressures so that renal perfusion is maintained. The patients with chronic arterial hypertension require a MAP target of more than 70 millimeter mercury because these patients who are uncontrolled hypertension and they are keeping a higher blood pressure, the autoregulation is hampered, and hence we require little higher mean arterial pressure for these patients. Now, in spite if the fluid resuscitation, but we talk about the goal-directed fluid therapy, is not able to maintain these pressures, probably the noradrenaline remains the drug of choice if we are not able to achieve MAP with fluid hydration. The transfusion practices, both anemia leads to AKI, and even as I mentioned in previous study, even the blood transfusions can lead to acute kidney injuries. So this means probably we need to prehabilitate these patients preoperatively in a high-risk population so that their anemic status is taken care of, and hence we are reducing the chances of RBC transfusion. And this is important here because the anemia should not be treated with RBC transfusion. Anemia should be treated with nutritional supplements during the prehabilitation phase of these patients, because the transfusion itself can lead to acute insult on the kidney and hence becomes important. We need to avoid the nephrotoxic drugs. We should be avoiding the contrast. We should be avoiding the NSAIDs. We should be maintaining a glycemic control in these patients in the postoperative period, because they can further precipitate acute kidney injuries. Try to maintain a sugar of 110 to 140, 150 in these patients. And also, it has been seen that those patients who are cachexic, because renal cachexia is a terminology that is being used nowadays, wherein these patients who shows renal cachexia will have poorer outcome. They will manifest more chances of AKI. The pharmacological intervention. Now, this is an interesting one because we have used various drugs which is said to have increased the urine output, especially the dopamine and the diuretics, the loop diuretics. But it has come with strong recommendation that diuretics is not required to prevent AKI or treat AKI. Only it has a sole indication that for some reason, if patient has been fluid overloaded, you want to decongest the body, you can use them. It is also recommended not to use an acetylcysteine and soda bicarbonate in patients who are manifested AKI. It is also recommended that there are various drugs like mannitol, dopamine, phenyldopamine. Phenyldopamine has some role. Atrial natriuretic factor, the N-acetylcysteine, the insulin-like growth factor. Now, these were the agents that were used for preventing or treating the AKI. Now they have been found whether either they are not useful or they can even will not have impact on the outcome. So these drugs, mannitol, dopamine, or loop diuretics, does not have much role in improving the outcome of these patients who have suffered acute kidney injuries. Now, this is an interesting fact which was extrapolated from the cardiac injuries, where the ischemic preconditioning was said to be done. It's an experimental stage. Probably this may come into picture after some time. They have been well tested in the cardiac surgeries where the organ is placed into a non-lethal episodes of ischemia to precondition the organ so that they can tolerate more lethal ischemic insult. So this probably has some role, and what they do is the cuff pressure is placed around the upper arm, is inflated to 2300 Newton mercury for 5 minute duration, and then the pressure is released, followed by several repeated cycles. So this type of ischemia to a body will release certain markers into the body, and probably patient will sensitize, precondition for ischemia which is happening to other organs, and they will try to compensate for it. We need more data for renal preconditioning, that whether this is really going to affect the occurrence of AKI or the improvement in the AKI. So I already mentioned about these drugs. These drugs has not been found useful. Dopamine, many studies, meta-analysis, no role now. This may increase the renal output, but outcome is not affected. Dopexamine, no renal protection, should be avoided. Loop diuretics, they are effective against pigment nephropathy, nephrotoxic agents, because they will just try to clear out the things, but they do not have renal protection effect as such. They are not going to prevent AKI or treat AKI, so there is much role. The mannitol, which is an osmotic diuretic, again, they will not have much effect. Calcium channel blocker is one agent which has some impact on the, causes the renal vasodilatation, and they can have some impact on the improving the integrity of these patients, and can be used. The atrial natriuretic peptide, they don't have much role. Phenyldopamine, they causes some amount of vasodilatation, and hence where you think that the renal perfusion is affected based on your Doppler studies, you can use them, but their regular role for the prevention of acute kidney injuries does not have much role. Now, last couple of slides, in case if the AKI is happening in the post-operative period, what to do? These patients are in the ICUs for management of these patients. What are the modalities that we need to look for? Now, when these patients go into post-operative period, either with sepsis or other components, they can be having AKI because of some septic focus, major surgeries, especially the intraperitoneal surgeries, low cardiac output, especially because of septic conditions, hypovolemia, or certain medication, nephrotoxic drugs that are possibly leading to the insult to the kidney, leading to acute kidney injury. The RRT, the renal replacement therapies, are one of the important tools that will help to compensate transiently till the kidney starts recovering. I've already mentioned in the beginning that how the kidney starts improving its own function within days to weeks. And hence the RRTs will give a transient support to the kidney so that it starts recovering well. The various inflammatory markers comes down and hence the recovery becomes much better. The RRT should be given, these are the standard indications in the post-operative period of the patient who are showing signs of acute kidney injury, primarily based on the electrolyte imbalance, the fluid overload, the uremia, or other complications, specifically the metabolic complication that can lead to the indications of renal replacement therapies. What we do is either we do a filtration versus dialysis we need to look for, and continuous versus intermittent therapies for renal replacement therapies are the main reasons. Now, there are various techniques that are being used for renal replacement techniques. The hemodialysis is one of the important. The ultrafiltration is one of the important, which are doing intermittently every 1 to 2 days, depending upon the electrolyte imbalances, the fluid overload, and the levels of creatinine levels. Sometimes, specifically those patients who are having, say, hemodynamic instability, they are not tolerating hemodialysis. Probably the sled would be more useful to these patients to provide them renal replacement. And sometimes even we provide them a continuous therapy using hemofiltration techniques or hemodialysis, or a combination of both of them in the form of continuous veno-venous filtration versus dialysis, which probably provides continuous supplement replacement of the renal functions. And we can choose either them depending upon the patient's requirement. Now, I think because of lack of time, we may not be going to detail much about these dialysis techniques. I think we can have more detailed discussion of various renal replacement therapies subsequently in some more lectures. But yes, we need to understand that the hemofiltration, what we are doing is basically we are pumping the blood through an extracorporeal system that incorporates a semi-permeable membrane through which the extra amount of toxins and the blood and the overload of fluid is being taken out. Hemodiafiltration is using a combination of both filtration and dialysis so that toxins and the overload of fluid is being removed from them. And this is how it works basically when we talk about the hemodiafiltration. That on one side, the dialysis is going into this apparatus. We are giving the replacement fluid, the patient fluid comes, which is usually anticoagulated, goes into the pump and is being taken out. And this is the chamber where diffusion is acting across semi-permeable membrane, across a concentration gradient where the various toxins are removed and that the blood is pumped back to the patients along with, if required, some replacement fluid. Continuous ultrafiltration is primarily for removal of the fluid overload, wherein these patients pose signs of congestion and hence can be used for this purpose. I think we use a lot of vascular access. So I said these patients are immunocompromised. So be very cautious that you maintain good aseptic conditions while insertion, and they are taken care of during their maintenance phase also. They are also a potential source of thrombosis, and hence the coagulopathy is an important issue. Not only bleeding, but thrombosis can also happen. So be careful about this. The anticoagulation, there are a couple of things. Usually the patients will be requiring some amount of anticoagulations while they are undergoing these type of renal replacement therapy. So for anticoagulation CRT, the KITCO suggests the use of regional citrate anticoagulation rather than heparin in patients who do not have contraindication for citrate. So heparin-free dialysis avoids the concerns related to various amount of coagulopathies. Now, it has to be, the technique needs to be chosen. So there is nothing specific depending on these criteria. You can choose the technique, whether you want intermittent hemodialysis versus continuous technique, depending upon the cardiovascular status, the availability of resources, and so on and so forth. And this is probably give you a fair idea. This chart will give you a fair idea that what are we going to remove? Is the patient showing signs of toxemia? Or is the patient just showing the signs of fluid overload? Based on this, we can choose either of the techniques here. Now, this is a question I mentioned in the beginning, when to begin RRT. There have been debates versus early versus late initiation of renal replacement therapies. The results are conflicting. There is no direct outcome which has been proven. If you see these various studies and even a meta-analysis, which I'll show you, in which this big meta-analysis published around 2 years back, they have mentioned that the early initiation of RT in critical ill patients with AKI does not provide a clinically relevant advantage when compared to standard. So this means we have to wait for the indications of RT to stop. And when to stop RT? This is again an issue, because if you continuously use it for longer duration, again, it is a potential source of infection, leads to other issues. So we have to discontinue RT when it is no longer required, either increasing kidney function has recovered. So we can look for the trends which are improving and look for the endpoints that we can look for. The RT can have various complications, try to look for and manage them. This is just not related to the kidney dysfunction, but also related to renal replacement therapy techniques, and hence we should be following them. So to summarize, careful preoperative optimization and optimal anesthesia care can guarantee the successful management of patients suffering from any amount of renal dysfunction. The development of AKI is under-recognized because it will be manifested at a later stage, specifically in those patients who have preoperative normal renal function, but it has a potential for potential significant consequences if it is not identified. Effective preventive strategies rely on their identification of patient at high-risk factors. So we need to identify those patients, high-risk patients, who have the potential of AKI, and they may not be detected earlier, and hence the use of various biomarkers are being accepted more and more, specifically in those patients who have a high index of suspicion of AKI on the background of normal kidney functions preoperatively. Preventive strategies include hemodynamic monitoring, fluid management, glycemic control, avoiding nephrotoxic drugs, which can decrease the incidence of postoperative AKI. Thank you so much.
Thank you, Dr. Rakesh. It was an excellent presentation. So,
thank you, Dr. Rakesh, for the excellent presentation. You have covered from the preoperative till the postoperative and techniques of RRT also. So it is very useful to clinicians as well as anesthesiologists. So we'll look at some questions, sir. There's one question, sir. There's one question from Dr. Sumat, I think. Should furosemide be used in a new onset AKI, cause being other than hypovolemia, if urine output is less than 0.5 ml per kg per hour, or should it be avoided?
So as I mentioned in my slide, the use of these diuretic agents are very specific. So unless you are expecting that it is, you want to just flush down the fluid overload that has happened because of the renal shutdown, probably you can use it, but it's not going to improve the or protect the kidney functions. So this renal function is not going to become better with furosemide. Specifically, when you think that some amount of tubular deposition is happening, maybe because of the contrast and all those agents, probably you can use it transiently to flush the kidney to avoid further damage, rather than using an agent as a preventive measure for the kidney functions to recover. So accordingly, we have to use it. So routine use is not suggested. Only in specific indications where you are looking for the pigment nephropathy, you can use them.
The second question, sir. What modalities can we try in such a scenario before embarking on dialysis?
So I just mentioned, one is the early identification. So once, suppose I just try to divide the condition into two situations. One, those patients who already have a chronic kidney disease, and they leads to having acute on chronic condition. Now these patients will be easily identifiable, so we have to look for the occurrence of acute kidney injury. The second group is more of an issue. those patients with normal renal functions, and if they have acute kidney injuries, will be missing the initial aspect, because until as the 50% of the kidney tubules are damaged, will not be able to identify clinically. Now we have to identify these issues. And in both the issues, what we need to do is we look for the underlying possible cause, whether it is a prerenal phase, which will be more commonly the fluid-related issues. Second, look for the intraoperative handling of these patients. Sometimes the retroperitoneal surgeries, the chances of acute blood loss, the need of blood transfusion, these are the factors which can increase the possibility of acute kidney injury. So prehabilitation and optimization is one aspect. Anything which has happened unexpectedly and the patient comes into high risk factors, we need to look for these patients subsequently. Fluid hydration remains one. The cardiac vascular monitoring remains one. Try to maintain a 60 to 70 millimeters of MAP. Those patients who have uncontrolled hypertension, try to maintain it somewhere around 70 to 75. Adequate control of sugars. Avoid nephrotoxic drugs. Adjust your antibiotics according to the renal function of these patients, because again, they are nephrotoxic. So remove all antibiotics which are nephrotoxic. Try to avoid NSAIDs in these patients. Try to provide a good pain relief to these patients, because pain itself is a potent vasoconstrictor, leads to decrease in the renal perfusion. Look for the surgical aspect, because sometimes when there is some amount of intra-abdominal bowel edema, that leads to increase in the intra-abdominal pressures, right? And this abdominal hypertension is again leads to decrease in perfusion. So look for those parameters and try to treat it. Maybe you have to open the abdomen for some time to decongest the abdomen so that the renal perfusion becomes better. So these are the various modalities that you can think of depending upon your patient assessment, in case if they have a high index of suspicion of AKI or they are manifesting in the form of AKI.
Hello, Dr. Pavni.
Yes.
Hello.
Sir, yes, sir.
Yeah. Good evening, Rakesh.
Good
It was an excellent presentation, but only a few things which are practically very important for us, particularly in the post-op period. So when before establishing or before identifying patient developing AKI, the commonest issue everyone will face is when the urine output comes down only, it's an alarm, and people will start looking at the patient. Urine output has come down. So this is the stage where we have to identify the pre-renal versus renal. So the commonest practice, and the people now, some individual level, they practice like a fluid challenge. First of all, they have to differentiate with the pre-renal versus renal. Then one more clinical bedside examination, fractional sodium excretion. So just try to address about these two. Anyhow, once the AKI developed, all the modalities, treatment, everything we have to go. But before that, can we pick up, identify the pre-renal level itself, and how to go up to pre-renal if patient is still in the pre-renal level and urine output has come down, and comment over fluid challenge, still individual level, people are using that. And then fractional sodium excretion, urinary fractional sodium excretion role.
Absolutely. I think you have just mentioned important points, because picking these patients at early stage, and a couple of studies have also mentioned for the fractional sodium excretion rate, which they analyze and look for the occurrence of kidney injuries and identifying them. But then subsequently, there will be many other factors which could be affected. And that's why these biomarkers has come into role now. So yes, absolutely, biomarkers are not available. So conventional testing, which has been done earlier, looking for the fractional excretion of sodium in urine, looking for the urine output trends in these patients, also looking for the creatinine levels in these patient trends. In fact, even we don't have to wait for 1.5 to 2 times to diagnose AKI, but they have an increasing trend. So looking for these parameters, definitely they will be indicator. But as I mentioned in some of the slides, these factors will be affected by many other things also. So hence, they may not be isolatedly clearly indicating the occurrence of AKI. We need to have high index of suspicion in these patients, and then supplement them with biomarkers. Probably it will give you an earlier marker. But yes, clinically, biomarkers are not available at all places. So as you rightly mentioned, that we have to look for these markers also to identify these patients for acute kidney injury. And simultaneously, the list that I have given, those patients who are at high risk of AKI needs to be a little more cautious. Rather than having a urine output of less than 0.5 ml per kg per hour, wait for it. Suppose, for example, a patient is having 2 ml per kg per hour and same fluid levels, now it becomes 1.5 and then 1. This is the time we should think of at why the patient's urine output is decreasing before the patient finally goes into a renal shutdown. So we have to look for the trends in the renal function and try to identify the high-risk factors and treat the patients accordingly.
Thank you, sir. There's one more input from Dr. Vibhavari Naik. She says, thank you for a great talk. She has a question also, sir. Intraoperative pneumoperitoneum can reduce urine output due to renal vasoconstriction. How low urine output is acceptable in such a situation? What are the strategies to mitigate AKI in such a situation?
I think this is an important question because during the creation of pneumoperitoneum, because it causes increase in the intra-abdominal pressures and various metabolic changes and local perfusion deficit do happen. And it's just not the perfusion deficit, but also the local metabolic changes that happens leads to decrease in renal perfusion, leading to some amount of kidney injuries. How low urine output and what should we do about pneumoperitoneum? So usually we say that keep your pneumoperitoneum pressures as low as possible, keep the duration as low as possible so that the renal perfusion is maintained. Now, this is like a little controversial, specifically in the intraoperative period, though the urine output has become one of the important parameters for global perfusion, and we take urine output as a marker. But in certain situations, the exact urine output may not be depicting the true renal status at that point of time because it is transiently affected by that particular intervention, surgical intervention. And hence it's become too difficult to say that how much impact will it have. But yes, at least 0.5 ml per kg per minute of the urine output should be maintained even in these situations. And once the pneumoperitoneum is released, the kidney should start throwing the urine back again. And that should be seen. In case if it is not, this means we are missing some aspect on the pre-renal failure probably here, and we need to target those things so that the renal system gets flushed appropriately with fluid administration.
Dr. Ramakrishna Reddy, your inputs?
Dr. Rakesh, one more common issue. This is one of the factors like hypoperfusion to kidney because of hypovolemia, hypoperfusion kidney because of sustained hypotension. So which is a more, the factor responsible for AKI? This is always debatable. Hypovolemia, hypoperfusion, and hypotension, drug-induced, maybe drug-induced or a cardiogenic, whatever it may be, hypotension, hypoperfusion to the kidney. So these are the two factors, commonest factors we come across intraoperatively and post-op. So what is your,
I think both the factors are important. I exactly do not know which is more important than the other, but both the factors are responsible for hypoperfusion of the kidney. I think if you see the studies which has been mentioned in various factors, the hypoperfusion because of the hypovolemia has been an important parameter because it will, the hypotension body will have some compensatory responses inside the body, and they will be in the influence of some of the anesthetic drugs. For example, they're putting up a regional block, epidural block, or a spinal block. Patient will try to compensate for it. But if the patient is in true hypovolemia, the compensation may not be as strong, and the chances of hypoperfusion of the kidney will happen. So majority of studies will talk about give the fluid status, and that's why these tools which are coming up for the goal-directed fluid therapy are more indicator of it. So, and that's why if you see, I remember somewhere is around 2000 or so, many of the studies were coming up with restricted fluid regimen, and they were saying the outcome is good. But then subsequently they found that though some of the outcomes were improving, like for example, say bowel edema and so forth, but some of the outcomes were not so good. And that's why they come restricted fluid regimen is not okay for many of the surgical procedures, and then they shifted. No, it should not be a restricted fluid regimen. It should not be liberal fluid regimen. It should be directed to some goal, and that is how the goal-directed fluid therapy is coming up. And I think for that reason, hypovolemia is one of the sinner for the occurrence of AKI.
Exactly. Many studies have proved that hypovolemia, a sustained hypovolemia for longer time, So there can be reversible changes and all. Yes.
There's
Thank you.
one more
Thank you.
question, sir. Can we know the source for GDFT algorithm used in the presentation?
The algorithm that I showed.
One algorithm, sir, GDFT algorithm.
So I can share you the algorithm that is with me. So I can send it on WhatsApp to Dr. Ramakrishnan Reddy, sir. So you can share it to your group. I will send that article.
There's another input from Dr. Vibhavari Naik, sir. She says, yes, she agrees to what you said. Avoiding hypovolemia is very important when associated with renal vasoconstriction due to pneumoperitoneum.
Absolutely, I think this is important, and sir was also saying the same thing. And what we have been told conventionally, I think, is applicable today. That before the creation of pneumoperitoneum, it is always good to fill them, these patients, not overfill them, fill them, these patients with fluid, so that the renal perfusion is maintained. So they should not be hypovolemic, because whenever we induce anesthesia, there will be some effect of anesthesia leading to vasodilatation and cardiac depression. So just fill them with some fluid before the pneumoperitoneum is created, so that the impact of pneumoperitoneum is compensated by the fluid that you have given to them. And we have seen that they maintain the perfusion well.
Yes, Dr. Veeresh Garu?
Yeah.
Anything from your side? Yes, Aditya?
Yeah, same thing. Thank you, sir, for your wonderful lecture. And almost you have covered every part of it, both prerenal, intrarenal, and post-op, and also therapeutic levels in laparoscopy, intra-abdominal pressure, and induced hypotensive cases. And inadvertently, what happens during the spinal renal anesthesia, temporary or continuous hypotension. You have given some guidelines, and we are very happy to have you on this. And you already told that goal-directed regimens therapy, and they will be sending it to our secretary. Then we will be passing on to our colleagues. Thank you very much, sir.
Thank you.
I think we have
Sir, Deepak, sir?
Aditya, do you want to say anything? Aditya?
Aditya, you wanted to say something?
Yes, sir. Let's Deepak sir. Deepak sir is there online? Sir, good evening, sir. So one.
Good evening, sir. Any input from your side, sir?
Hello.
Sir, good evening, sir. Any
Yeah,
input?
Rakesh.
Yes, sir. Good evening, sir. How are you?
Sir. Fine. This is a wonderful. These biomarkers you were talking about, how much time will it take for these biomarkers to show up the acute kidney injury, or immediately it will affect?
No, immediately they will not show, because the various biomarkers are released from the endothelial cells or the tubular cells. So majority of these biomarkers, if you see, if we compare biomarkers versus serum creatinine levels usually will take around 16 to 24 hours to show a rising trend. Whereas most of these biomarkers, especially the NGAL and KIM, they will start rising within 1 to 2 hours, and they peak around 3 to 4 hours. So these probably are the earlier markers that can be used. NGAL is being used in majority of studies, and at this site also we have used in a couple of patients and have found it useful in identifying earlier.
Yes, Dr. Aditya?
Okay. Thank you.
Good evening, sir. Very lucid presentation. Sir, two questions. For example, patient of CKD, is there any role of antioxidants in preventing any AKI or AKI on CKD?
I think to my knowledge, there is no role of antioxidants which is being used for the purpose of preventing AKI. They have some role specifically only when we talk about the contrast-induced nephropathies. Primarily, there also hydration is to be maintained rather than use of these agents. They have some role there, but intraoperatively, other regions of AKI, the surgical causes, to my knowledge, I don't think there is any role of use of antioxidants for the purpose of prevention or for the purpose of treatment of AKI.
And sir, one more question. Patient of CKD, where there is an accepted hyperkalemia or on the borderline hyperkalemia. For example, if this patient goes into an arrhythmia, is there a possibility that when we use a sodium channel blocking agents like lidocaine for any arrhythmia, does it cause a refractory arrest?
Can you just repeat the question again, sir?
in a patient with CKD, where there is a borderline increase in the potassium level, or say high normal level, and this patient throws an arrhythmia for any reason, and we use lidocaine as an antiarrhythmic. Are we blocking the sodium channels and the potassium channels leading to a asystole? Is there any advisory on that?
I'm not very sure about the advisory, but when we talk about the hyperkalemia-induced arrhythmias, which happens like in the form of, say, VT or VF or cardiac arrest, in those situations, I don't think we are looking for the use of these antiarrhythmic agents, because the reversal of hyperkalemia will be using calcium and other antidotes for it. So to my knowledge, I don't think addition of lignocaine is going to help in reversing the arrhythmias.
My question was, sir, patient is having a borderline potassium level, say 5.5 or 5.7. He has not developed arrhythmia because of hyperkalemia. For some other reason, he has developed an arrhythmia. And you want to use...
In that sense, you have to use the standard practice for those arrhythmias. If you think for other reasons, look for the reason for arrhythmia. Because as I mentioned, when we talk of the chronic kidney disease, there are multiple reasons for metabolic disturbances happening. There could be acidosis, there could be bicarb changes in these patients. These patients' phosphate levels also changes. So there could be multiple reasons for the metabolic disturbances leading to cardiovascular instability can happen. So we have to look for. But if they are showing very telltale features of the cardiac arrhythmias, lethal arrhythmias, then the standard practice remains the same. And especially if you say borderline potassium, say maybe like 5 or 5.5, these patients, especially when they have acute blood loss, lot of tissue handling, there could be sudden surge into the potassium levels. So just do a ABC analysis and see actually what is the potassium status there, and then treat them accordingly, sir.
Sir, there's one more question, sir, from Dr. Sumat. How much do these renal biomarker tests cost in India?
Cost, I do not know, because I am working in a government hospital and it is free for the patient. So I do not know exactly how much they are costing, because for us, the patient is getting free of cost. But they are kit-based test. Maybe I will just check it from my colleagues who are working in the laboratory, that how much the kit costs for them.
Sir, good evening, sir. One more doubt. How much percentage of the kidney damage to cause chronic kidney disease? Some nephrologists will say it is 30%, 15%, and then comes the 7%, like that. Does it depend on the times, how many times in a week you go for dialysis, or any other parameter that the kidney percentage of cells damage due to this chronic kidney disease happens?
Sir, usually we say up to 50 to 60% of the tubular damage is not manifested in the form of decreased urine output or increase in the serum creatinine levels. So till time we have a sufficient reserves into the kidney for maintaining the urine output. So by that time, nothing will happen. And then subsequently, the definition of CKD that we have mentioned, below that level, once the patient start having more and more damage to the renal glomerulus and tubules, then they will start manifesting, and accordingly there will be some plateau level of creatinine level at each. And now, actually, what happens is, so this is one. So when we talk about chronic kidney disease, we are ensuring that at least half of the kidney has become non-functional. So there is damage to the glomerulus kidney. Now, based on subsequent damage to the kidney functions, we have graded them into various categories, various grades of the CKD as per the classification. But what actually happens is, now these kidneys are more prone for damage, because if there is some underlying reason, it's a diabetic nephropathy, it's a hypertensive nephropathy, it's a myeloma nephropathy, if they are sensitive to NSAIDs, it's a single kidney. Now these kidneys are more prone for further any acute insult, which otherwise may not be causing much insult in a normal kidney. So that we have to look for when we are managing these patients. For example, say a single kidney. When somebody has two kidneys, we use NSAIDs, no issues. But when we have single kidney, we don't want to use NSAIDs in these patients. Not that all patients will be affected, but sometimes it can cause a decrease in the renal perfusion, and hence we avoid them so that we are not damaging them. So depending upon the renal status, our evaluation and planning should be made accordingly so that we are not subsequently further damaging the kidneys in any form, and hence we should be careful. Similarly, will be applicable, as Dr. Vibha Naik mentioned, about pneumoperitoneum. Patient with single kidney, patient with renal transplant, we should be cautious when these patients are being given pneumoperitoneum, because higher pressures will compromise more kidney dysfunction in these patients, and hence we should be more cautious.
Thank you. Thank you.
Thank you, sir. Sir, what is the role of these vasopressors in in acute kidney injury, sir? Is there any dose limits and all that?
No, there's not exactly dose limits, but these are double-edged swords basically. So first target should be that we are reversing the reversible cause. Second, we are maintaining the fluid status. And then in spite of this, if the patient is not maintaining the mean arterial pressures of around 60 to 70, we have to start the vasopressors, and noradrenaline remains the drug of choice, because other agents probably will cause decrease in the renal perfusion. There is nothing very specific, but then when the dose of these vasopressors are being escalated, this means there is something continuous mechanism which is causing insult to the kidney. So more commonly, like for example, sepsis. Sepsis is one. So unless we try to target it, so it's just not the increasing dose of vasopressors or increasing amount of fluid. We have simultaneously to treat the cause. Send these patients for various culture sensitivity and markers like procalcitonin level for these patients to look for sepsis, and start the antibiotics early, and probably will be able to come down with the dose of vasopressor. Because
usually they are usually against using norepinephrine, sir. So many such situations we face. So they say norepinephrine is not very good for the kidneys and all that. So in such situations, what are we to do, sir?
So I think earlier, if you remember earlier, maybe around 2000 and 2005, dopamine was the drug of choice. But there are now ample number of studies, even with systematic review and meta-analysis. Though dopamine transiently can increase the urine output, but it is not going to have impact on the outcome of the kidneys. So that's why dopamine is not the selected drug. Similarly, mannitol was being used for flushing the kidney and just to increase the output. It's an osmotic diuretic. Again, mannitol is not having any role. Only drug that you can use for increasing the pressures will be noradrenaline right now. And obviously, if you go for very high level, say 1.5 mics per kg per minute, obviously it will is going to decrease the renal perfusion, compromise renal function. But simultaneously, remember that the fluid status should also be appropriate. Hypovolemic patients with vasopressors will cause hypoperfusion of the kidney, and hence we should be cautious.
Yes, sir.
Thank you, Dr. Rakesh Gar.
Thank you, sir.
On behalf of ISA Telangana, for readily accepting our invitation. So it was a nice presentation, touched all the aspects. So I think it will help us in coming days in managing the patients in the intensive care unit as well as immediate post-op period. So I thank Dr. Veeresham, President ISA Telangana, and Dr. Pavani, our moderator, and all the seniors and my colleagues. So in future also we will invite you for various topics.
Sure.
Hope you will accept.
Thank you so much.
Nice, so nice. Yeah, thank you.
Thank you, sir. Thank you, ISA, for giving me this opportunity to act as the moderator for our esteemed person, Dr. Rakesh Gar. Thank you, sir.
Thank you, dear Dr. Rakesh Gar. And we will invite you according to your convenience to our webinar. Thank you.
My pleasure, sir. My pleasure.
Thank you so much, sir. Thank you.